Hey YouTube, how you guys doing? Okay, so I wanted to come on and talk about falls, and I saw a recent video posted about falls, and I really want to put my spin on it and how I respond to falls, the assessments I do, and yeah, that's it. Let's get into it. Okay, so if you're thinking about working in long-term care or you just started, I'm here to let you know falls are a part of long-term care. You can try your best to prevent them, but our patients have minds of their own if they want to walk, and they don't always listen to us nurses and CNAs. Start out by saying there's two types of falls. There's a fall where the person falls in for whatever reason they fall, and it's also considered a fall. Say you're walking with a patient and they start losing their balance and you lower them to the floor. That is a fall too. So there's three phases to a fall. There's the admission phase, where you are receiving a patient into your facility and you have to figure out, like, is this patient a fall risk? And 9 times out of 10, the hospital or whoever will tell you, but you can always, I think you can always do your own assessment. You can assess for orthostatic hypotension, you can look at their meds and do a care plan based on that. But this is not what I do at work. I'm not in that role where I'm getting an admission. So I'm not even going to talk about that because truthfully, I don't know all the ins and outs of admissions and how they go. Okay, so there's that phase, and then there's the time of the actual fall when the patient's on the floor. So at that point, there are certain things that need to be done, and also policy needs to be considered before you get them up. The third phase is after the fall, after the patient, you got the patient up. Then there's about 3 or 4 things that need to be done. Okay, and one is, again, an incident report. And incident reports are policy. They are not nursing documentation. They are policy, and we will get into that. But anyway, so there's those 3 phases to the fall. There's the admission, where you're assessing the patient for the risk of fall. There's the time of the actual fall when they're on the floor, and then there's after you get them up, now what? Okay, so before a fall actually happens, as a floor nurse, as a regular nurse, not one doing an admission, just a floor nurse, you know, there's certain things you can do to prevent falls. So do that. Like, there's certain patients that are just gonna walk back and forth. They're restless, and you need to make sure their floor is clear, or put their wheelchair right next to the bed. Like, do lock their chair if they're in bed and gonna get into the chair. You know they're gonna get into the chair. So do some prevention, lower beds, you know what I mean? That kind of thing. That's before a fall. Now, when the patient is down, they're on the floor. Here's the thing, did you see the fall? Because if you saw the fall, then it's considered a witness fall. If you heard the fall, you're outside the room and you heard the fall, that's not witness. That is not witness. Your eyes had to have seen that patient, and the only reason that's a factor is because if you saw that fall, you know for a fact that that patient did not hit their head. And that's what matters with the unwitnessed fall. Did they hit their head? Okay. So unwitnessed falls, they get neurochecks. Witness falls, they don't need neurochecks unless you saw it, but you're like, oh, they could have hit their head. Then you do neurochecks. It's not cut and dry, but if there's any doubt in your mind that maybe they hit their head, you start neurochecks. You be safe, okay? when the patient is down, keep in mind all falls are incident reports. So for incident reports, you need certain information, okay? Incident reports are like to figure out what happened and why did it happen, okay? That's what incident reports are for, and it's for quality control. And incident reports are there in case there's litigation connected to this fall. In case like somebody sues over this fall. Okay, just like the Christian Gainey case. That nurse, I believe, was sued. And they had evidence against her, blah, blah, blah. I'm not getting into all that. I'll be talking for an hour. So when you're thinking about an incident report, you need to be like, why did this patient fall? Who was with this patient? And then you need to go to the CNA and be, not immediately, that's after. So I'm getting ahead of myself. But what position are they sitting in? Are they 2 feet from their bed, or are they right in front of their bed, and chances are they fell getting up out of bed? So you can put that as a possibility. And then just take into consideration, like, are they in any distress? Are they grabbing their arm and being like, ow, ow, ow? Of course you're gonna note that. Of course. Look at the time, note the time of the incident, and then just look at the surroundings. Is there a puddle of water on the floor? Is there a pair of shoes on the floor that they tripped over? Are they sitting next to their bed? Are they 3 feet from the bed and the walker's over there? Like, look at the situation. Do they have sneakers on? Do they have non-skid stuff on their feet? Because that's their injury. Or check their skin. Have them try to move their arms. Tell them to move their legs. Rule out, like, look at their legs before you have them move them. Be like, look for external, like some crazy rotation. But chances are, if they have that type of injury to their bones or their joint, then they're gonna be in some kind of pain and distress. So if they're not in any distress, look for an injury. Check their head, make sure they're not like, they don't have like bruising and this and that, because we have to rule out head injuries with falls, because that is the most dangerous complication from a fall. Okay, head injury. So while they're on the floor, if they don't object, get their vital signs, check their pupils, get that first set of neurochecks done. Check skin, and then note time of fall. And then when you're done your assessment and you assess the environment and you assess the patient, blah, 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 how do you get them up? This is policy. This is where policy comes into place. 1, with the incident report. 2, with how you get them up. A lot of facilities nowadays, they have lifts. You get the patient up with the lift, because if you lift this patient up off this floor, because you don't want to take the time to go get the lift, if you hurt yourself, that's on you. You have to eat the medical bills. You have to deal with that injury. You know, like, do not pick a patient up if it's not policy, or if you think like, maybe I'm gonna hurt myself, like this patient's kind of big, blah, blah, blah. Be careful with your body. Yeah, get them up per policy, okay? And if you don't get them up per policy, you can put in the witness statement or the incident report or in nursing documentation that you picked the patient up, because corporate is not gonna like that. Okay, so now you did your first set of vitals, you assessed the patient for injury, you checked their skin, their level of consciousness, you know, their speech, like check their orientation. So once they're up, if it's a witness fall, or you're not sure if they hit their head or not, you continue on neurochecks. I think neurochecks are like every 15 minutes for the first hour or two, and then every 30 minutes, and then every hour, and then every 2 hours, then every 4 hours, and every 8 hours for 12 hours. Like, they're just so long, but you need to assess your patient on a regular basis once you have a fall. On a regular basis. Again, Christian Gainey case. She did not assess her patient. She did not, and if she did not get a baseline from the right people and this and that. So know what you're doing and find someone who's known this patient for at least since admission, or who has been working with them for years, or somebody who knows this patient. Be like, is this normal for them? Because a lot of dementia patients, older people, they're not normal. So you have to know, is this their normal? Just like some people's blood pressure runs high. So is this their normal? You have to get your baseline after you assess the patient. You have to get their baseline because you have to know if there's a change in this patient after the fall. And then the next thing you have to do after you get your baseline, you continue neurochecks, you get your baseline. Now you have to put them on report so that the following shifts are monitoring this patient and it just doesn't get swept under the rug and lost in the communication. Like, a note is not good enough. They have to be on report. And so the nurses are monitoring this patient, and all the CNAs know that this patient had a fall and we need to keep an eye on them. Care plan. Say you have a fall and they tripped on, and the patient said, I tripped on my shoe over there and I just lost my balance. Then you would care plan. Patient states this and that. You would put that in the incident report. And that also, a part of incident reports is corrective action. And the corrective action, 9 times out of 10, goes in the care plan. So you, as a floor nurse, if you're on 3 to 11, or you don't have your unit manager, or you're on 11 to 7 and a patient falls, you should be putting in some intervention. Clear the clear floor of clutter. Assess room for clutter. Some kind of intervention like that. Figure out how to word it, put it in a care plan, so if you leave that building early, or you go on break and they fall again, or you leave that facility because your shift is done and your unit manager, or something crazy happens where nobody gets to the care plan on morning shift, at least you did an intervention and you educated your CNAs. You can put that in the incident report. And when I say incident report, I mean incident report. I don't mean the nursing documentation. Why did the fall happen? And put something in the care plan. Because if somebody else doesn't get to it, then there's this delay of care, and you were the one that walked out the building without ensuring that something was in place to prevent another fall. Incident report. You have to put, how did it happen? Now, if you weren't there, you don't know how it happened. If the CNA was there and she says this, that, and the other happened, you write in your witness statement or in the incident report, CNA states blah, blah, blah. Because if you don't say with your 2 eyes, you can't say this, that, and the other thing happened. It's hearsay. Because you could be lying and not even knowing it, because a CNA or a therapist or a family member told you what they wanted to tell you. So you need to put CNA states, therapy states, this, that, and the other thing happened. So if someone comes to you You don't know what happened. Don't ask me. My incident report says this person said that, so go ask them. They were the ones with the patient. You may have had a part in it before the fall. You may have, and then you have your assessment after the fall. That's what you know, before and after, but you don't know the time of the fall. So don't sit there and act like you know in your documentation. Okay, in your incident report. I have my documentation tips video. Check that out. Like, there's some mistakes you can make with documentation, okay? And they're big. They could be big. Okay, they could be big mistakes. They could have real consequences. So if you do these things before and at the time of the fall and after the fall, you'll be fine. You'll have nothing to worry about. So let me know if you have any questions. And if you watch this long, thank you so much. You know, I appreciate it so much. And let me know if this video helped you, because I love hearing it. I love your comments. And let me know if there's anything that you want to hear about. That's it, guys. I will talk to you later, and be safe.